Welcome to Medical Mondays. I'm Lisa Carberg here at News 8. Our special guest today is Dr. Catherine Rotker. She is a Yale urologist, and we're talking about infertility in men. We hear a lot about infertility in women, but we're going to talk about infertility in men in depth. There are a lot of options, a lot of exciting things going on. First, take a look at this story, my report. Doctor, welcome.
Thank you.
So, doctor, let's first watch our report. I came out and interviewed a lovely couple from Madison, and then you were part of that. It was your patient, and let's take a look at that. Connie and Michael's story. Connie and Michael Bakutis were a COVID couple who easily had a baby girl in 2022 and planned to expand their family. But with no pregnancy after months of trying, they sought help from Yale urologist Katie Rotker.
Unfortunately, about 15% of couples who try to conceive are going to have difficulties. And in those couples, about 50% of the time, there's a male factor or contribution that's making it difficult to conceive.
Dr. Rotker ran tests that revealed Michael had no sperm. She describes Michael's condition as secondary infertility, when a man conceives a child and is then unable to.
We didn't know really how to take that because we had just conceived with our daughter about a year and a half ago.
An office scan then revealed Michael had something called varicocele, an enlargement of the veins that carry blood from the testicles. 20% of men have it, but it only impacts fertility in some.
We use a microscope to actually separate the veins from all the other structures in the cord, and then we clip or tie those veins.
Dr. Rotker informed the couple that only in vitro fertilization, or IVF, may work when sperm is injected into a harvested embryo in a lab. There was also a chance it would not work.
If we weren't able to conceive another child naturally, adoption would have been the next step for us as a couple.
But 10 months later, their family grew. Connie got pregnant, and they welcomed a son.
We wanted another child for our family, and now that he's here, we are complete, and we went through the hoops to have him, and we felt very settled and at peace once he was finally here.
Dr. Rotker, what is it like when you have patients that have success like that?
I think it's the whole reason you do the job. They're such a wonderful couple, and getting to see a family expand in the way that they want and meet their dreams and goals is so gratifying and rewarding.
And when you have a couple in this situation, you have to have some tough conversations. You go over all the options and treatments, which we will talk about in the next segment. But you really have to prepare them. I've been through the infertility journey, and it's not always easy. But boy, what results. Tell us about Michael's condition, varicocele.
So, a varicocele is a very common condition. About 20% of the population of men have these dilated veins above their testicle. Most of the time, it's really not a problem. The three reasons we kind of worry when a varicocele is there is if it's large before puberty, in which case it can affect testicle growth, if it's causing pain, which is relatively rare, and if it's affecting fertility. But most men with varicoceles, it really won't affect fertility. However, when we do look at the men who have issues with fertility, more than you would expect have these varicoceles. And if we fix them, we can improve semen parameters in the vast majority of those men. So it becomes a really effective tool in helping couples to conceive.
And what is the problem with varicocele? The blood doesn't get through the veins. How does that work?
Yeah, nope, the blood is going through. The idea is that the backup of that blood, that sort of pooling that happens from those veins dilating, acts almost like a blanket on the testicle, keeping it just a few degrees too warm. And that temperature change is what is felt to affect the sperm production.
And what you did, you described what you went in and did surgically. Is that the only treatment for it? How does that work?
So in some cases, we can just watch these. Again, not all varicoceles are a problem. Some cases you can do something called embolization. This is where my colleagues from radiology use a wire to get down into the veins and release material to try to get those veins to shrivel up. And then the last option, and the one that we often do for fertility purposes, is a surgical repair. So this is a simple outpatient surgery, small incision with the kind of stitches that melt on their own. And the patient is able to go home again that same day with a relatively short recovery.
So after Michael had that done, explain to us why IVF was his option.
So at the time that we did his varicocele repair, he had no sperm in the ejaculate. In men who have some sperm, the varicocele repair can increase those numbers, and we would often wait to see what happens. In his case, when there's no sperm, it is more rare that we will get return of sperm to the ejaculate after we fix a varicocele. Worth a try, but certainly not a guarantee. So at the same time that we did the varicocele repair for Michael, we took some sperm directly from the testicle, and that is what they used to conceive their new son. However, in the good news category, after the varicocele repair, he actually did have return of his sperm production into pretty normal ranges, to the point where we had to do a vasectomy to prevent them from having now an unintended pregnancy.
Very ironic, right? And
Yes.
and so when couples get tested, we went over some of the guidelines. What's the usual path for couples, for men to get tested? I feel like women are at their OBGYNs religiously every year, and they can get tested easily. They're more likely to go to the doctor, maybe. What does it take to get to the man's testing for fertility?
Yeah, I think recognizing that that testing exists is part of the first step. And then getting to my door can be a little bit difficult. That referral can come from a primary care physician. So, talking to your primary or general doctor about what's going on is one way. Often, that referral will come from the female partner's OBGYN or fertility doctor. So, they'll recognize that this is a couple issue and send that referral my way. Once they are evaluated, the process is pretty simple. It involves a history that's pretty detailed, looking for risk factors. It involves a physical examination to see if there's anything physically that we can find, like a varicocele. And then it often involves semen testing to look and see what's going on in terms of sperm production.
Real quick, 1 minute left in this segment. How did you detect the varicocele? It was done in the office, I understand.
Yeah, that's actually a diagnosis that's made based on physical examination. So it's
Ah,
just a simple
okay.
exam to feel, and I can feel for these dilated veins on exam.
All right, Dr. Catherine Rotker, Yale Urologist, stand by. In our next segment, we're going to talk about some of the men's infertility treatments, options, some of what are the latest and greatest. We'll be right back. We are back with Medical Mondays. Yale Urologist Catherine Rotker is joining us, and we saw your success with a patient. That was wonderful. Doctor, let's talk about men's infertility. Where do we stand with options, treatments? What do men have available?
So it is such a varied population and so many different reasons why a couple might not be able to conceive. So a lot of the options are very based on what we're finding. In some cases, we find pretty normal sperm parameters, but couples still not able to conceive. And there are lifestyle changes we can make and some advanced testing that can be done to try to uncover ways we could improve the situation.
Tell us about some
Other
of
times,
those.
yeah. So, one test we do in couples who are having trouble conceiving or having recurrent miscarriages is something called DNA fragmentation testing. So, this is specialized semen testing that can look at the sperm not to see how many there are or how many are moving, but instead to see how much damage is accruing on those sperm. And there are things we can sometimes do to change that and improve a couple's chance of conceiving.
What would you do?
Depends on the situation. Sometimes, if they are having recurrent failed IVF cycles, we can get sperm directly from the testicle, which has less damage than an ejaculated specimen, and we can use that for the IVF cycle. There's also lifestyle things we can do to improve that sort of damage that's occurring. So, antioxidant use, lifestyle changes like quitting smoking, losing weight, not drinking excessively can help. And so there's a number of paths depending on what we're finding and what we think the causes are.
How much does the man's lifestyle and health practices affect the health of a baby?
I think that the data that's coming out on this is fascinating, and depending on how you look at it, very exciting or very terrifying. So I think for a long time we felt like if complications happen during the pregnancy, we talk about something called preeclampsia, where the mother's blood pressure goes up during pregnancy, or gestational diabetes. We're finding that there's a close link between developing these conditions in the mother and the health of the father at the time of conception. And so I think that there is a whole world that we're going to find that the health of the father has much more of a role than I think we thought in the past.
That's very interesting. Did that surprise you, or how did you take that?
Yeah, absolutely. I think for a long time, all those pregnancy outcomes have just been assumed to be a female partner problem. But again, we're learning more like that, again, the health of that male partner at the time of conception matters. And I think for the health of the offspring as well.
All right, let's talk about more options for men's fertility. What are some other things that you can do, maybe surgical or otherwise?
So again, it's a little dependent on cause. One population we see are men who have made a decision to get a vasectomy in the past, thinking that they were done with their fertility choices, and then for one reason or another want to expand their family again. And so in those cases, we can extract sperm for use with a process like in vitro fertilization, or we can even do a surgery where we reverse the vasectomy to allow a couple to attempt conception naturally again after a vasectomy.
What is the
Um,
effectiveness on that?
eh, Very highly effective. So a vasectomy reversal, all comers has up to a 95% chance that you can
Wow.
have sperm in the ejaculate and maybe a 75% chance of pregnancy. How long it's been since the vasectomy can affect efficacy of that procedure. And so there's some nuance to that, but a very highly effective procedure. However, generally not covered by insurance, so it represents a high out-of-pocket cost. So I still counsel men that a vasectomy should really be thought of as a permanent option, and that vasectomy reversal should sort of be a last resort.
Do you do the vasectomy? Are there any new advances with maybe robotics or anything in along those lines?
Interesting. Yes, I do a lot of vasectomies. It's something I do very commonly. I don't use a robot. I don't know of any robotic advancements. I do something that's called a no scalpel vasectomy. So we make a very tiny puncture and we're able to access both vas deferens through that tiny puncture. No need for stitches or staples at the end, just a small band-aid over that puncture site.
And what do you physically do? What are you reconnecting?
So for the vasectomy itself, we're disconnecting the vas deferens, and that's the tube that carries the sperm from the testicle up into the ejaculate. When we do a vasectomy reversal, that's a much more complicated process. It's a larger incision, and we have to use an operating microscope to tie these very tiny tubes back together using stitches the size of a human hair.
Wow.
So that becomes much more complicated than doing the vasectomy, which is a very easy office-based procedure.
Tell me about for the reversal. What is that? You said it depends on the time frame that can factor into it, of how long ago the man had that done. Tell us about that.
Yeah, so there can be some back pressure that occurs over time after a vasectomy, and sometimes a secondary blockage can occur in the epididymis, one of the structures right outside the testicle. And so, in those cases, if you just reconnect the tube where it had been cut, you've really missed the problem because the blockage now exists further down the path. And so in those cases, we can do something sort of like a bypass where the tube is reconnected directly to the epididymis. Um, but success rates for that procedure are a lot lower. The chances that that blockage develops certainly increases over time. So we say if it's been more than 15 years since your vasectomy, that the rates of needing to do that kind of bypass go up. Still not guaranteed that that'll be needed, just higher rates over time.
So you have a regular surgical way, and then the bypass is step two, or it's your go-to if that doesn't work, or they're not a candidate.
That's more dependent on whether we see that sperm is coming through the tube.
Uh,
And so at the time of surgery, unfortunately, can't test for it beforehand, but at the time of surgery, we can see is there a blockage or is sperm coming through? And if coming through, we do the traditional way that we just mentioned, but if not, that's when that bypass might be necessary.
all right, Dr. Catherine Rotker, we will be back right after this. We are back with Medical Mondays. I'm Lisa Carberg, joined by Dr. Catherine Rotker. She is a Yale urologist. And doctor, I know you work out of Lawrence Memorial, Yale in New London. Do you have another office or location?
Yes, I also see patients out of the Orange office, the Yale Fertility Center.
Excellent. All right, so doctor, let's talk about some other urologic issues you see in male patients and how you help them.
So I specialize in addition to the male infertility that we've been talking about at some length, in erectile dysfunction, low testosterone or hypogonadism, and men's health. I do see patients across the spectrum for urology, including women, but my specialty is certainly in these conditions.
All right, let's talk about erectile dysfunction first. What causes it? Just tell us a little bit about it and what are the treatment options at this point in time?
Yeah, so erectile dysfunction is very common. Studies will suggest at least 50 to 60% of men by the time they get into their 60s are going to have erectile dysfunction. There's varying causes. Most commonly is going to be other health issues that accumulate and damage the vessels over time. So things like high blood pressure, high cholesterol, diabetes, obesity, diet and health choices, all these things we know affect our vessels, and those accumulate and can affect erections over time. But there are other causes, sometimes things like nerve damage, certain surgeries can put patients at risk for developing erectile dysfunction. And then it can even be a psychologic or psychogenic problem where stress, anxiety can be a major contributing factor.
What are the treatment options?
So we have a lot of treatment options. I think most people have heard of the pills. So sildenafil or tadalafil, brand names are Viagra or Cialis, are common medications that I think most people have heard of in terms of treatment for erectile dysfunction. But there are other options. Certainly, lifestyle changes can make a difference in terms of erectile dysfunction. We also have medications that work directly on the penis itself to create erections when needed, even when the pills have failed. And there's even surgeries that can help to obtain erections for patients who none of these other options have been viable.
What types of surgeries?
The main one we do is something called penile prosthesis placement. So I sort of describe this like a knee or hip replacement you might get if a joint was not working anymore, for erectile function.
And is that an outpatient surgery procedure?
Most It can be outpatient or a one-night hospital stay, depending on the device and the surgical risk factors. But yes.
Are most of your patients satisfied with the pill version that you were talking about, the Viagra's, the other ones?
I think satisfy is maybe not the word. Not everyone responds to the pills.
Ah,
So for
okay.
those who they do work, that can be a great option. But for patients who don't respond, that's not where it ends. So if you don't respond to the pills, it's not like all your choices and options are over. There are other things we can do.
All right. What about low testosterone? You mentioned that. Tell me what you see. Who is a candidate for this? How do you treat it?
So the interesting thing about low testosterone is it's been associated with a huge number of symptoms: fatigue, lack of desire or libido, weight gain, loss of muscle mass, brain fog. So there are a number of reasons why we might experience any of those symptoms. Testosterone is just one of them. So to get a diagnosis, you really have to have both a blood test showing that you have a low testosterone level as well as symptoms. And the idea is to improve those symptoms through improving the testosterone level. And that can be done through diet and exercise in some cases, through medications that try to get the testicles to make more testosterone in some cases, and most commonly by replacing the hormone that your body is not making. So that's sort of by giving testosterone.
Is age a factor in a low sex drive or lowering as you get older?
There's certainly a decline in testosterone that happens as men age, and I think it's a little controversial what is normal and what do
Ah,
we have to live with, right? And so again, I think this is where the number is not enough. You have to have the symptoms and the number in order for this to really be considered the condition.
all right. Tell me, what else do you see in men's health?
So I think under erectile dysfunction, is just a small part of sexual dysfunction. So we talk about things like premature ejaculation and issues with ejaculation. We talk about hormonal issues, and then I treat men for other conditions that are more common in urology. So making sure that we're doing cancer screening like prostate cancer and bladder cancer. I treat kidney stones. So I think, and urination symptoms in large prostates, another very common thing we as urologists treat. So looking at sort of the whole picture.
I know it can be hard for men sometimes to get to the doctor for certain issues, and women too. I mean, it's really personal. Do you ever use telehealth with men to try to make it easier? How do you try to bridge that gap of fear to maybe go into your office and admit they have a problem?
Yeah. Um, Absolutely. We offer telehealth visits. And I think that one of the reasons I love my specialty is it can be the reason that brings men back to the doctor and back to thinking about their health. So when you're having trouble conceiving, maybe you haven't seen a doctor since your mom made your appointments as a teenager. And this is the thing that brings you back to seeing and getting your health evaluated. Or, when your erection stopped working, that is the sort of red flag that brings you back into the healthcare system that you maybe haven't been going for a while. And so I think that's an honor and a privilege, and part of the job that I take seriously is making sure that we're thinking about the patient as a whole.
That's very nice. All right, we have 1 minute left. Let's circle back around. When should couples seek fertility testing?
The guidelines would say that if it's been a year of unprotected intercourse, that is when you should start seeking care. But I always tell couples that if there's any niggling doubts in your mind or other risk factors you might have, seeking care earlier is perfectly reasonable. So if the female partner is over 35, if there's any other risk factors you know about, seeking care earlier is very reasonable.
Well, Dr. Catherine Rotker, we appreciate you and your time and your expertise, and just keep helping those patients. That's wonderful what you're doing.
Always a pleasure to speak with you, Lisa.
Uh,
Thanks so much.
Thank you.